Hi, everyone. Welcome. We'll get started in 1 minute. We'll just let people join. Okay. Maybe I can get started with just a quick welcome. Thanks for joining us this afternoon. I hope you've enjoyed the conference so far. I know there's a lot happening, so we're grateful that you've chosen to join our session. My name is Lily, and I'm one of the facilitators in this panel, and I'm a postdoc at the UBC Department of Psychiatry. And I coordinate a research cluster at UBC called Matrix N, and I'll tell you a little bit more about it in a bit. But first, I would like to acknowledge that UBC and Vancouver are situated on the traditional, ancestral, and unceded territories of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. And I am privileged to reside, learn, and work on this beautiful land. I know that you're all joining us today from many places, near and far, so I encourage you to take a moment to acknowledge the traditional owners and caretakers of those lands. And Indigenous people, including youth, carry a disproportionate burden of social suffering in Canada. So when we talk about patient and youth engagement and care and research, it's crucial to include Indigenous voices and culturally safe approaches. So now I'm going to just quickly share one slide where we are going to stay off of slides for most of the panel, but I just want to, can you see this?
Yeah. Mm-hmm.
So yeah, I mentioned Matrix N. Which is a multidisciplinary alliance for translational research and innovation in neuropsychiatry. That's where the acronym comes from. And we are, as I said, a UBC Research Excellence Cluster, which is funded by the university. And the cluster constitutes of, we have around 70 faculty and trainee members. And as a group, we seek to bridge gaps between research, clinical practice, and patient needs in order to facilitate innovative solutions to mental health challenges and the current overdose crisis. So all of the members of the panel today are members of the Matrix N Community Advisory Group, which is composed of researchers and people with lived and living experience related to mental health and substance use disorders. And this group aims to encourage open dialogue by creating a safe and supportive environment to share experiences and perspectives. And it creates opportunities for members to provide feedback on the cluster's research activities and to collaborate on research projects and events like this one. So the ultimate goal of the community advisory group is to gain insights on the unmet clinical needs related to mental health and substance use disorders, and to help ensure that translational research into new therapies is more patient-centered. If you would like to learn more about the cluster, please visit our website, matrixandcluster.ubc.ca, or there's my email if you have any questions. We'll be recruiting again in September for expanding our community advisory group. So if that's something that is interesting to you, please let me know or keep an eye out for the announcement. So now I'm going to stop sharing and I'm going to pass it on to Dr. Fiona Choi. Actually, first we can do introductions. So I'll go around the room. Everyone can mention their background, what brought them to the community advisory group, and kind of their experience or perspective on patient and youth engagement in care and research. I'll pass it on to Fiona first.
Sure. Thanks, Lily. Welcome, everybody. I feel very fortunate to be part of this conversation. So thank you for allowing us to share this time and space with you. I work as a researcher based out of BC Children's Hospital, and I'm very passionate about working with the adolescent population and in developing better tools and toolkits for early intervention and also prevention programs for high school students in order to reduce the harms of substance use and to support them better in building mental resilience. So that's my kind of area of work and focus. And in terms of bringing, what brings myself to this group, through my work and personal experience too, it's been increasingly recognized that the patient voice, and especially now when we discuss like youth-focused issues, that the voice of patients and youth themselves really need to be heard. I think that the system of care responds to population needs. It really should be responding to population needs, and it should be built on evidence-based practices and well-researched approaches. So then I think the conversation has to begin much earlier in the process. So not only patient feedback, but earlier in the research process too, and understanding what are the better approaches, what works, what doesn't work, and how things need to change and improve and adjust. So I think that it starts, early on when you develop the research questions, what kind of outcomes should be looked at? How should programs be evaluated? What's considered effective? And who makes those decisions? Who's deciding whether something's helpful or not? So I think that those questions need to be asked really upstream from youth, from patients, from families themselves. And then we need to be open to pivoting and adjusting our efforts in order to meet those needs. So that brings me to this group, and I'm very excited where we can move in making this voice stronger and being heard. Yeah, thanks. I'll pass it to Morgan, who can introduce and share what brings you to the cluster.
Sure. My name is Morgan. I am a PhD candidate, I guess, at the University of British Columbia. I study biochemistry and neuroscience from a molecular perspective. Getting into science, I was really, I guess, interested in learning a lot about the brain from my own experience and lived experience of mental illness. I really enjoyed learning about neuropsychiatry and was kind of surprised when doing research, especially preclinical research, of the lack of patient perspective involved in, I guess, decision-making and experiment planning in preclinical research. And so I kind of got involved with the Matrix N cluster because I wanted to kind of encourage some experience of patient voices in this, especially, coming from a preclinical background. That was something that I was super interested and passionate about. And then I got involved in the community advisory group because, again, I'm very passionate about encouraging patient voices. And then also because of my own lived experience, I'm bipolar, that I have, I think something to add to a conversation. And I really enjoy hearing all of these people's voices as well. So maybe Rachel, you want to go?
Sure, yes. Hello, I'm Rachel. Very similar to Morgan, I have a bit of background in lived experience in addition to having a passion for understanding elements from a very technical and clinical level. And so I'm pursuing my master's in pharmacology, and additionally, I have lived experiences with childhood adversity, additionally chronic pain for over 15 years. And additionally, I'd like to say that I have a very spicy family, so not too much surprises me. But with my chronic pain, I found that I was talking with a lot of doctors, and I found that there was that gap between patient-oriented research. And so that's what brought me to this cluster that I'm very excited about. So I will pass it along to Ria.
Hi, everyone. Can everybody hear me well? Great. So I'm doing my master's in counseling psychology at the University of British Columbia. I chose this stream because coming from India, I've seen significant taboos surrounding mental health. And that made me really passionate about providing one-on-one support as well as mental health advocacy. I also did my undergraduate degree at UBC in psychology, and that's when I noticed that while there's a lot of research out there, it hardly reaches the masses, like people who could benefit from the most, because a lot of it has like this academic jargon that's hard to understand. And secondly, what fascinated me about the Matrix and cluster was that they were taking patient voices into account at a very early stage. So it was not about just sharing results, but taking into account the experiences while research is being conducted. And that to me was something so interesting for me. I personally had not seen before during my undergrad. So when I noticed this opportunity, when I came back to UBC for another degree, I was like, I cannot not be here. It is a wonderful initiative by UBC, and I'm just so fortunate to be here in front of all of you today speaking about such an important concern. I'll pass it on to Mahesh.
Thank you, Ria. My name is Mahesh. I'm also a visitor in the unceded traditional ancestral lands of the Musqueam people. I've been in UBC studying forestry for about 3 years and a half. That doesn't have much to do with this, but I'm a recovering addict. Or, I've struggled with substance use in the past. And I've navigated a bunch of different type of supports around different communities. I'm also a peer support worker at the student recovery community, which is a safe space for students to talk about substance use, addictive behaviors, and everything in between. And basically the reason why I joined this amazing group is because it's, as I mentioned before, I've navigated a lot of different types of support for myself, and I've encountered a lot of someone mentioned this, but like gaps, and most of these gaps are based on the lack of bringing in the patient and the decision making. So this is why I'm here.
Thanks, everyone. I mentioned my name is Lily. I'm mostly wear the researcher hat within this group. I do have kind of family history of mental health and suicide, and I've always been fascinated with what they call abnormal psychology, which there's already a problem with the language there. But yeah, mental health and substance use disorders. So yeah, I'm happy to be the cluster coordinator, but I'm more of a learner within the context of this community advisory group. So now I'll pass it on to Fiona, who will serve as our moderator for the panel discussion. And we've prepared a couple of questions to kind of get us started. And then please drop any questions in the chat, either on Feedloop or on Zoom, as well as if you have a question and would like to ask yourself, please raise your hand and we'll call on you to unmute yourself and ask your questions. So for now, I'll pass it on to Fiona.
Yeah, thanks. So yes, like Lily said, we did prepare several questions that the panel was, very passionate and interested in sharing about, but we are wanting this session to be dynamic as well. So very open to taking the discussion along those who are, that you're interested in amongst the participants. So please post those. But since we don't have any started yet, we'll go through some of the things that came up in terms of our discussion when we talked about patient and youth engagement in research and care. The first of which was this topic around stigma, and as it's related to addictions and mental illness, and how stigma affects the ability to seek support, and what kind of barriers that are there. So I'll start with addressing Mahesh with this question about stigma, and I want to hear what your thoughts are about how stigma affects the patient's willingness to engage in care or research.
Yeah, sure. I can definitely talk on that, especially because it has been one of the biggest barriers that I've encountered for myself. And just keep in mind that right now I'm just speaking from my own lived experiences, which are by no means any profession or anything like that. But as a student and as someone in like early 20s, navigating like the recovery process was something that I was not really prepared to. I don't think anyone is prepared to, but especially because we do not really hear much about it, right? And the only things that we hear around my age group is like, well, they're not nice things. So that's the first barrier, like stigma within my social circles. But then that escalates to like then trying to ask for help. You know, there's some things that I thought I was not gonna be able to open up with like professionals just because like, well, the first thing that happened was when I opened it about like having struggles with substances, um, there was like a pre-made definition of who I was and what I was going through, even though like it was not that realistic what was going on. So that was like the first time I ever like reached out for help, and it pretty much closed my doors for asking for help again. So yeah, I don't know if I answered the question, but it's pretty much, you know, it can tell like if I'm gonna be able to use the support or not. Like if the way that someone receives me as coming for help can, tell if I'm gonna, be able to keep seeking support or just like close my doors to any other type of support.
Mhm. Yeah, thanks. And for another panelist, Morgan, would you like to speak on this topic as well? Do you have some thoughts to share on how it could prevent people from being involved?
Yeah, so I was diagnosed bipolar when I was, I think, 19 officially. And the stigma around it, especially in an academic community, was pretty big at the time. I feel like as the people are getting older, the conversation is much more common on social media, at least for mental illness. I think substance abuse still has a lot of conversation to be had. But especially in an academic setting, the barriers kind of, I felt like I couldn't be myself. I felt like I couldn't be forward with the fact that I am this is something about me. And it felt a lot like when I got this diagnosis, it was a defining factor in my life that people were going to make decisions about me and for my care based on this factor in my life, which wasn't necessarily true for my experience. It does have a very significant role in my life, but I am still an individual and I still have, self-determination and my own care. And I found that that was true both in academic settings and in a medical setting, where it's like being bipolar. Obviously, when I went and met clinicians and all these things, people made assumptions about me based on that diagnosis that then, becoming a person who is educated, especially in neuroscience, when I sat down with my psychiatrist, he was like, okay, whoa, different way to approach you as an individual based on your diagnosis versus your individuality. And I think that stigma is a big part of that. And yeah, that definitely didn't help with me getting support throughout my journeys.
Mhm. So now then, do you think, as in someone who is engaging more in research too and wanting to hear the patient's voice, what are some suggestions you would have to diminish that so that people are more willing to maybe even participate in research or have their voices heard?
Yeah, well, I think firstly, having people in research that are open about their experiences. I mean, um, it's harder to make assumptions about people when you have a diverse representation of people with disorders. So when you see people who are recovering from whatever their challenges are, and they have different perspectives than just a maybe traditional patient perspective or I guess a lot of people assume like a victimhood perspective in a lot of these like diagnoses or whatever. And, having people who are researchers and also people who are peers that are contributing a research voice can really help inform people to make better assumptions and interact with people better. So, yeah.
Yeah, thanks. Oh, that's great. Great points. I thought we could move into maybe directing the conversation towards youth and engaging youth specifically, especially youth who are at higher risk, and how we can create opportunities to hear their voices. And maybe if you have any ideas on what are some differences between youth-specific engagement versus adults, and what maybe would have made a difference to you as a youth when you were kind of trying to navigate the system or trying to navigate it for peers or for family members or for friends. Yeah. How about Rachel? Love to hear from you on your thoughts on this.
I think one of the main differences for connecting with youth is for youth to interact with professionals or medical professionals that they relate to or they can see themselves potentially in. For
Mhm.
instance, for myself, I remember being 15, very angsty for multiple reasons. And I went into my first counseling session and, my counselor was wearing like a leather jacket and Converse. And I was like, okay, you might be okay. And that was a 15-year-old's perspective. But it was through that I was able to open up with her and build that relationship. And I still see her 15 years later. And so essentially, I think with youth there's this kind of tendency to very much see the world as it applies to you. At least I remember thinking that way for myself. And so for youth to potentially interact with people who can help fill in that gap, I think is going to allow them to open up more and to also decrease the stigma as well.
Mhm. Great. Yeah, thank you. Ria, do you have some thoughts on this topic?
I would love to. In terms of engaging youth, I would like to share an experience. In one of my counseling psychology classes, when I took a class on counseling adolescents specifically, we were taught that when it comes to the youth, it's important to realize that there is a stage wherein certain areas of their brain are very different from what you would see in an adult. So, for instance, the ability to logically reason and control their impulses isn't developed fully, as the prefrontal cortex area is not fully developed. Secondly, without getting more technical, the area in the brain responsible for sensation seeking is very much so heightened. Therefore, it's so important that we realize that seeking experiences to support the same is a very normal part of their development. Where I come from, in India, people tend to think the opposite, and sensation seeking any form is considered to be a matter of emergency. However, around the world, it is considered to be a very normal aspect of their development. So when you do discuss with the youth about these topics, it's important to take into account what development stage they are at and talk to them in a manner that is relatable to them. They don't like topics being spoken about as very black and white. Which is what parents usually do. You're just not supposed to engage in this. You're not supposed to do that, etc., etc. But if things are explained to them in a way that is it's natural to have curiosity. However, it affects your ability in the future to be able to say in your relationships, how you communicate, how you show up for work, etc. Then that is something youth are way more likely to understand, as opposed to saying like, I'm your parent and I forbid you from doing this. That's not going to work with youth. And that's why so many campaigns historically have failed, that have just refrained youth from engaging in a specific action. When youth are struggling, I think three things that they can take into account in terms of their strategies to boost their mental health is an increased sense of self-control, competence, and well as community. For control, I believe doesn't have to be anything big. It can be something as small as making sure your room is clean. Because having a sense of control over the space that is around you has been shown to boost their self-esteem. Competence can be then learning a new skill or mastering an existing one. Lastly, community can be enriched through a variety of means. While this can refer to family and friends, but there are also other areas of support they can reach out to, such as Foundry Virtual VC, wherein youth aged 12 to 24 and their caregivers can drop in or schedule an appointment. This is also available in person, and they can find peer support, get support with employment, access groups and workshops, or browse a library of tools and resources. I personally work with Kids Help Phone a lot, which is an anonymous texting-based support system where I supported over 350 texters in pain. And that question, Fiona, that you asked specifically about like what we wish was there as a youth, I wish this was there. Because when I was growing up, I didn't have any anonymous helpline. And I think that made such a big difference, because I've seen from my experience there how much difference it can make to just have a non-judgmental listening ear by your side. And as someone who growing up struggled a lot with like self-esteem, anxiety, and self-compassion, I know that it would have made a huge difference to have that kind of support. So in fact, I do feel like the youth today are at a good place where there's so much available around them in different formats. It's important to recognize that support looks different for everybody. So what might work for one person might not necessarily work for everyone, but it's good that there's a variety of resources. And I can, in fact, post some of them in the chat if that helps.
Yeah, that'd be great. And then we can also, I think, post it after the sessions on the web platform, like the resources and links, if anyone wants to go back to the session and find, yeah, the resources there, then we should do that. That would be very helpful. Thank you. Great. Now, how about let's move into family engagement? So we just had a keynote right before this session about families and how families can be the most important part of a youth going through crisis. In speaking about family engagement, what are your thoughts on our current system of engagement for families and families within the mental health and substance use space? What do you have concerns about it? How do you think it could be improved? And if you do have any of your own experiences or in your work as well, helping youth navigate through the system, how has families been involved or not involved? And do you have ideas on how that could be supported better? Morgan, do you want to try this one? Pass it to you first.
Well, I think getting started, everybody has a very different relationship with their family. And I think patient individuality always kind of needs to be considered. Individual autonomy is something that is super important. As a youth, as I think Rachel touched on a little bit, you are like rebellious and you do kind of have a very self-oriented view of the world. And so, you know, the taking away autonomy can be a pretty negative thing. But then alternatively, a lot of people have families that are like the biggest support systems, and relying and building on that support system and can be a really important part of individual care. But I think it does have to be taken on an individual level.
Mhm. Yeah. Any one of our panelists like to add to those ideas there from Morgan?
I guess I really like the description of that family situations can be very complex. And so I currently wouldn't say I'm a very big fan of the current systems. Is at the same time, family can also contribute to difficulties as well. And that may not always be recognized, especially if the medical professional is talking with the family member who may be potentially influencing certain directions as well. So I think taking a bit more of a combined potential approach would be a great direction to move forward in.
Mm-hmm. So again, at the center of the youth or the patient or whoever we're trying to support, right? And seeing what works best for them in their situation, yes. We have a hand up I see from Kathleen. Would you like to unmute and ask a question or a comment?
Can you hear me okay?
Yes.
Okay. So family dynamics can often be cultural or generational, and education is the key. But where do we start? Do we start at the school level with parents? Do we start with the kids on how to approach their parents? Where does this start? Because the family is the key. How do we get them involved when they have bias coming into the situation?
Great. That's a great question. Anyone on our panel like to address that or have some ideas? Mahesh?
Yeah, I have just one thought that came to mind, and it's one thing that I've seen, especially within my family, in my own situation, is challenging old ideas. And that has been basically the start of me and my family growing as a support system for myself and for so yes, as you said, education is very important. And as you mentioned as well, people come with like biases, right? And there's like biases that can be like generational from like years and years back. I'm coming from Mexico, which is, there's a lot of stigma around addiction still. And, you know, I was never talked to about these things, and mainly because they were things of like out of this world, right? And that's like a societal thing. Like we do not talk about this because it's not a nice conversation to have with like anyone, right? I'm just talking about like Mexico specifically, but like I feel like having it more as a normal conversation is the best way to like bring it in as a more normal thing, which is what it is, right? We were talking earlier about like how it can be like seen as a disease. You know, we talk about the flu like if it's like, you know, flu season and stuff like that. Why don't we talk about addiction like that, right? It's the same, you know? Yeah, and just like, you know, education is such a big word. I'll say more about like learning how to challenge ideas. Um, you know, yeah, it's a tough one.
Mhm.
Yeah, I can add to that a little bit. I think my own experience with my family was a little bit complicated in terms of education. I have a mixed ancestral background. My mom's side is indigenous and my dad's side is white settler background. Um, and there's different biases and different traumas on each side that kind of contribute to how they interpret and understand situations, especially pertaining to like mental health or substance use. I think on my dad's side, which is the more white, I guess, side of my family, they do have like some history of mental illness, and it was a very negative experience in which the person that had mental illness had passed away quite young based on suicide. And so when I did get my diagnosis, there was this automatic bias of this is the worst thing ever, these kind of things. And so having a conversation that this is not a terrible thing, this is, you know, we need to talk and we need to be supportive and not, I guess, have this automatic negative bias. Is something that's really important. And yeah, being able to have those open conversations is really, really important for families. And in terms of like how to encourage that from a more research or clinical side, I'm not exactly sure what the best like step to introduce that into is. I feel like you can educate youth a lot easier than you can educate I guess families, because youth are in like school or whatever and you can kind of approach them there, but families, it's harder to reach and approach them to encourage that education and the questioning. And for every family cultures are different. And so having a conversation about mental health and substance use might be okay for my family because, well, yes, there might be a negative bias there, at least open to having a conversation, whereas I can't speak for everyone's family where that's not necessarily an option.
Yeah. Lily,
Mhm.
you wanted to?
I just want to prompt you to tell us more. I know you go to schools and speak to youth and teachers and parents sometimes. So that kind of relates to Kathleen's question. Could you tell us more about that?
Sure. Yeah, so in working with students in schools, I've also had conversations with teachers and counselors, and we're trying to connect also with the parents. So in this kind of toolkit we're developing for high school students, we visited quite a few classrooms, and it does start with building relationship with the youth themselves. It takes a little bit to get to know the youth, but once you do, they're really open to wanting to share what their experiences are, what they need, what's missing. And they really, I think, often seems like they appreciate just an interest in their voice and being heard and being part of creating something that's meant for them. I think a lot of times programs and solutions are created for youth, but not with youth and by youth. So I think that's a really important part of the process. And what has resulted from there looked very different from maybe how it was imagined from the beginning. And I think that's because of this co-creation partnership with youth. In speaking with them, it is varied, and I hear it throughout our conference today too. Like not one thing works right and well for everybody. There's just so many individual circumstances that change through the person's stages as well. I mean, what they need at one point in time is different from others. It's always fluctuating, and we have to respond to that. I know it's hard as a healthcare system to, I think, do that appropriately because things can be quite rigid based on guidelines, policies, practices, and things that are sort of institutional settings. But what I've learned through conversations with students is there are so many different reasons for example, substance use. For some, it's really an experimental period where they just wanted to experience something different. It's a trial exploratory use of substances. And for others, it's dealing with masking some social anxiety, or sometimes it's a feeling of low mood that they really just want to feel better. So whatever that can make them feel better, that they can access is sort of helpful. And so I think it's recognizing that substance use many times serves a purpose, and it can have very positive effects as well. So going to youth and say, well, substance use is just harmful, there's risks. Yes, they need to be, I think, aware of the risk, probably like recognizing signs of overdose, what to do in the event that they suspect a friend or a peer is having an overdose, how to call for help, and how it looks different. You know, overdose based on different substances can look different. And I think recognizing those signs and having those knowledge pieces is helpful. But beyond that, I think it's also understanding that there is this benefit or usefulness of substances. And then it's understanding what their motivations for use are. So do they need further resources in dealing with like body image issues, or is it cyberbullying that they're dealing with and that substances is a way to cope? Or are they just really stressed from either family situation or is it academic stress? They need, you know, better tools at managing that. There could be conflicts they have within their family that needs to be resolved, or they maybe need to be removed from dangerous situations. Like there's so many different reasons and things that youth are contending with, that I think we need many different avenues to reach them, and then many different options that they can then choose to see what's most appropriate. Yeah, and then if families can be brought into this conversation, that, and I think most of the time could be quite beneficial. And then there needs to be a lot of family education on what are more supportive communication patterns that they can be developed and worked on. I think that's always very helpful too. Yeah. But yeah, thanks for that question, Kathleen. Do we have any questions from the chat or audience that's posted, Lily? I don't know if I'm keeping track of the both platforms.
Yeah, not on Feedloop as far as I can see. There was a comment in the chat. Let me see that addiction, it was from Kathleen again, that addiction is a disease, and she often hears people say to someone who has a substance use difficulties that you have a disease. You should get help. Does this really help? Sorry if I didn't do your question justice, Kathleen. But yeah, it goes back to the stigma and whether defining addiction as a disease helps or, you know, detracts from seeking care, for example.
Let
Yes,
me clarify.
Kathleen. Mhm.
Yeah, just let me clarify. So what I was trying to say is that, you know, you say, well, if somebody has diabetes or heart disease, they go and get help. So when you're dealing with youth, using those examples, and because it is a stigma, is it really going to be helpful? Can they relate to heart disease and diabetes and the fact that they have a disease and they need treatment? I don't know what you're finding. Is that a good way to approach it with them, or are there better ways to talk about it?
Mhm.
Am I making
yeah.
sense?
Yeah, I think Mahesh had a comment for that, yeah.
Yeah, I think especially talking to younger folks, it's very important to like try not to make it like negative. You know, talking about a disease and bringing words like maybe you're sick, you know, can be very negative. I dare to say like it's as negative as like all the dare movement. Because like, you like quickly feel identify as someone sick or as someone negative, I feel like the best approach is to, coming from a place of compassion, bring in all the signs of what being sick means rather than, qualifying it as a sickness. Because like what is addiction, it's like for me, addiction is something that someone will like self-identify as, someone struggling with substance use or something like that. Here like at the SRC we say like it's a safe space for students who come and talk, but also like to explore their relationship with substance use, right? You know, we basically meet whoever's coming where they at, because we understand that people are not necessarily identifying themselves as, you know, um, you know, struggling or in addiction. I don't know if I answered the question. It's basically what we try to prioritize is to put whoever's coming before, like putting them in the steering wheel of what their progress or what their support will look like, rather than putting them in a single basket of like, this is a sickness and you're in here.
Mhm.
Helpful, thank you.
I think kind of to add a little bit to that, I think this is a good example of a difference between like maybe adult acts or speaking with adults versus speaking with youth, because I do find that kind of analogy very useful when speaking with like older family members in my own family and my own care, because it's like originally this like really negative thing. It's like, okay, well, I can just get treatment and I'm okay. It's the same thing as my sister is actually a diabetic type 1. And so it's like, it's not that much different from what's wrong with her in my experience. But I think that that's my own ownership, that I can say that, okay, I have this thing, I can get treatment and I can do better for myself. But I think it does kind of rely on identifying what you're struggling with as a disease. And oftentimes mental illness and substance use are kind of more complicated than that, because it's not like being neurodivergent is not necessarily a disease. It's just a difference. I think it needs to be seen that way too, but can be helpful to communicate with people who can relate to the disease idea.
Mhm.
That's all the questions there are in the chat right now.
Mhm.
Do we have any other takers?
Okay. Then I know that, we had, as a panel, we had talked about previously about just your experiences. So I thought it'd be uh, interesting to dive into a little bit more if you want to share about your experiences as you transition from kind of a patient role to then being maybe in peer support role or to academic research, and kind of ways that you found you could integrate some of these experiences together, and what that was like for you, if you're open to sharing that. Ria, would you like to speak to this?
Sure.
Just like the value of lived experiences.
I think I don't have the same experience, like lived experience, but I do have experience supporting others that have lived experiences. I've supported a lot of people in pain, especially through the crisis line. I think that has added a lot of perspective, because it's very easy to otherwise, um, like, assume what it's like. But only when you hear from the world people in pain can you actually tell what are their needs and how exactly we can meet them, like what the gap is in terms of what they need from the government, as like kind of support that they need around them versus what they are receiving. I think I've tried a lot to incorporate that in my practice now. Like when I look at mental health advocacy opportunities, what I want to do once I get my license to practice, and it helped me a lot in terms of that, like not just approaching it from a helper's point of view, but also like what can I do to meet my patients where they are at.
Mhm,
I mean, that it's really helped widen my knowledge base.
mhm. Great. Mahesh, I see you wanted to speak to this.
Yeah, I love the topic of lived experiences because, you know, I've tried a lot of different types of supports before stumbling my way into the student recovery community. And, I've said this a couple times before, and this is just coming from like my experience, and don't take this as a like, I don't know, as something like real or whatever. But there's this saying that it's like no one understands an addict other than another addict. And again, it's don't take it as like super real or whatever. But it's just it's very powerful because like I can relate to experiences, right? Hearing the person who was like supporting me, talking about what they were going through and what they went, opened up this like door that made me be able to like be vulnerable enough to like share my own experience, right? To talk about a little bit about my experience like in the transition to like, becoming a peer supporter. Um, so as I was mentioning before, I stumbled into the SRC, mainly seeking support. And then I was approached by these people who had lived experiences and were like, amazing enough to like open up and share their experiences that I just fell in love with that. And I keep saying to myself, like, I'm doing this because if I can prevent someone going through what I went through, you know, the job will be done. And the way that we do that is basically by listening and like by sharing what we have, and it's a very like important topic as well because like my addiction and my past for me was something very negative, and being able to use it as a tool to supporting others, it's just very valuable because I completely changed the narrative of something that was the worst became something that it's like my best tool and the only thing that I have to be able to like prevent people from going through like what I went through. So yeah, I'd say lived experiences is like pretty important when we're talking about recovery.
Yeah, thanks for that. Rachel, you had some ideas to share on this too.
I think it's absolutely like brilliant and very true. For instance, for myself, like over my lifetime, I've seen a lot of doctors, and I was very lucky to find an amazing clinic. And it wasn't until I think a year into the treatment, after talking with these different doctors, where I found out that they themselves had had chronic pain in different types. And then that out of all the doctors I've seen, it was the doctors that had had a similar experience to mine that were able to help me. As for the transition between patient to kind of researcher, I can't speak for everyone. I've found it a little awkward at times. It kind of feels like I'm having to translate everything into different languages in a different type of a way. I also kind of forget what things are sometimes normal to say in conversation or what's a kind of an unusual experience. And so that's happened a few times where, I'll just be talking about something very casually for me. And then I see someone's face and it's like, oh, okay, that's not normal. And so essentially, I think that potentially in order to help others transition, just continuing to maintain like an openness and acceptability and kind of allowing for some bumps and some adjustments, I think would be a good direction going forward.
Mhm. Yeah, that's great. Thank you. There's been comments made in other sessions I hear too that we really lack professionals or individuals who are trained, who understand, who are part of the conversation. But I think that there's a movement and slowly changing. I mean, all of you are junior scholars in this group who are trying to advocate. At the same time, you're also very dedicated to the research side, and you're volunteering, you're working and supporting those who are struggling. So bringing all the different hats, right? All the different lenses you have is shaping the future of healthcare, of the system and the approach. So I think there's definitely a step in the right direction, slowly maybe, but surely. How about just looking ahead then, how do you envision the relationship between patients and clinicians and researchers to change in the future? So just projecting forward, do you have any thoughts on how these relationships might be affected by the conversations we're having, or how can they kind of constructively move forward as next steps? I know that's, I don't know if it's a very multi-layered question, but sort of just your ideas on kind of moving forward. How are these interactions that you can see changing? Just to kind of leave it on that note too, because I know we have about maybe 10 minutes or 9 minutes left of the session. So we'll just go through everyone on the panel and can speak to sort of moving forward. How do you envision this changing? Anyone want to start first? Mahesh?
Sure, yeah. I remember mentioning or talking about like accessibility, and just like being able to put out there opportunities for people who are like struggling with substance use or with mental health more accessible, because like it could be very positive. It can make patients, and speaking for myself, feel very very empowered and very in control of like my situation. Kind of connecting it to what I was saying, it's like it can be an opportunity for me to feel that I'm being able to use my past that I used to not see as something positive for something positive, right? So the way I envision it is, just more accessible, like making this like an ongoing thing, a kind of, working hand by hand, patients and researchers, and openly as well, like being able to like say it out loud that we're working together.
Yeah. Great. Ria, do you have any comments on this?
Yeah, I would just say, like how we've been talking about meeting people where they are at. I think collectively there's a lot of emphasis on that. They know that there has been this gap we've discussed extensively in terms of what patients feel they need. Like Mahesh mentioned, whether it's accessibility or anything, like what they have identified as concerns. And now there's more emphasis on prevention and harm reduction and just making sure that you're able to incorporate patients as active members in whatever kind of treatment they're receiving, whether knowing their opinions firsthand, educating them so they can make informed decisions. I think it's not so. Back in the day, I felt like we just had to accept whatever was given to us, and there wasn't much dialogue between different people involved. But now there is that emphasis on making sure that all these bodies, whether it's the patient or the clinician or researcher, they're working together as a unit to meet the patient's need, as opposed to the patient trying to like, as opposed to being all very fragmented and then having to navigate through a vast amount of information on their own. I think that, to me, I feel like hopefully that's where the field's heading.
Right. I hope so too. Thanks. And Rachel, how about for yourself?
I think potentially what could really help improve things is for those who, maybe are at the front lines or maybe even a little bit higher up in terms of medical professionals, is kind of finding a way to approach them. And as a reminder of, you have this manual, and this manual is very helpful and it's been great. At the same time, though, that manual is not going to apply to everyone. Bits and pieces might. And so just, potentially going forward and trying to finding a way of informing people who, are responsible for helping, that, you can break from the manual, you can break from the mold, especially if someone needs it, and that's okay. Yeah, I think that approaching it from that would be a different layer as well, in addition to just providing more tailored type treatments.
Yeah. Great. Thanks. And Morgan, what are your thoughts?
I mean, I think everybody summarized things beautifully. I think the only thing that I really want to add is the inherent power dynamics in the medical model need to be kind of really challenged and thrown out the door when it comes to incorporating patients meaningfully and respectfully with clinicians and researchers in the future. I think oftentimes as a patient, you get spoken down to, people come to you and you're like, they are in the authority and you are not. And in a discussion like this, we all need to be wearing the same level of hat. We're all equal conversation partners. And I think if clinicians can start treating patients as like equal partners in their own care and their own discussion, that it would really benefit patient outcomes, because having self-determination, having independence and the ability to make your own decisions in your own care, and whether or not you even want that care is a very important part of moving forward as well.
Mhm. Yeah, thank you for that. And then Lily, we haven't heard as much from you because you were facilitating, but what are your thoughts on this moving forward and all the different kind of ways that you're involved in research and clinical systems?
Yeah, so a little bit like Morgan, my research initially was exclusively preclinical. So I would read obviously papers and inform myself on the clinical need and whatever is relevant on the literature that's relevant to my project. But rarely, if ever, did I have to actually think about the patient, their perspective, or how my research can be applied and make sure it has more of an impact than just publishing in a journal or posting the results online. So yeah, it's been a great learning experience, and with this cluster, with this community advisory group, and as well as a researcher, yeah, it's becoming more and more clear to me how important it is to involve patients and youth and kind of community perspectives throughout the research process. As we mentioned at the beginning, kind of not only sharing the research findings, but including patient input in the design of research, making sure that they're treated, as Morgan said, they're not talked down to, but they're considered a part of the research team, that they're compensated for their time, they're given credit, as authors on papers, or as co-applicants on grant applications, or as, participants in events like this. So yeah, it's been a learning experience for me, and I'm glad that this topic is getting more and more deserved attention.
Mhm. Great. And I thought those are good last words, Lily. We could wrap up our session. So thank you very much, everyone, for attending, for asking the questions, sharing your comments, and then the panelists for being so open and sharing your insights and your experiences. And I really do hope that we are taking steps forward, sometimes a couple of steps back, but then we move forward again. So I am very hopeful for some transitions. Great. I hope everyone enjoys the next session. I think we're leading into the wrap up soon. So it's been an eventful and long day. So I hope you all enjoyed it. And we'll see you in the next session. Thank you.
Thank you. Thanks, Fiona, for facilitating that. And thanks everyone on the panel. And enjoy the rest of your day. Thank you.
Thanks.
Bye.